Hello everyone, welcome back to my YouTube channel. This is Learn and Move with Kalani. Welcome to today's session on cartilage injuries, where I'm going to talk about the pathophysiology, treatment, and rehabilitation following cartilage injury. Cartilage damage, especially in the knee, is a common challenge in sports medicine and rehabilitation. Today, we will explain why cartilage has poor healing potential, how we can treat these lesions, and the best strategies for rehabilitation. If you are a sports physio or someone dealing with the injuries, this video is for you. Make sure you like this video if this is really useful and subscribe if you find this content is valuable. So let's get started. Here is what we'll covering today. First, we will discuss about the basic science of articular cartilage, about cartilage lesion and the healing challenges associated. Also about the effects of loading and nutrition for the cartilage tissue. Then classification and diagnosis of cartilage defects, treatment options, and finally, the most important topic, rehabilitation phases and return to sport. Cartilage lesions in the knee are particularly difficult to heal because cartilage is avascular, aneural, and alymphatic. This means it has no direct blood supply, no nerves, and no lymphatic drainage as well. So, making the repair and regeneration in cartilages is really limited. As a result, cartilage injuries often lead to severe symptoms where reduced knee function occurs, and if left untreated, it can progress to osteoarthritis also. Even in the 18th century, William Hunter stated that an ulcerated cartilage is universally allowed to be a troublesome disease, that it admits a cure with more difficulties than a corrosive bone, and that when destroyed, it is never recovered. So, if we discuss about the cartilage morphology, it includes four main layers in it, which serves different functions. The first layer is the superficial zone that acts as a resistor for the wear and tear. Next, we have the middle zone that performs the function of load bearing. Then coming the deep zone for the shock absorption, and finally the calcified zone for the structural integrity. Damage to these layers affects the joint function significantly. The key players in the cartilage structure are chondrocytes and extracellular matrix. Chondrocytes are known as the active elements, whereas the extracellular matrix is considered as the reactive element. This extracellular matrix is made up of collagen, proteoglycans, and glycosaminoglycans, and because of those, it provides its unique biomechanical properties of the particular cartilage tissue. As we all aware, proteoglycans and glycosaminoglycans are essential as they bind water, making the cartilage resistant to compressive forces. Since the cartilage is avascular, it relies on two main processes for the nutrition. One is diffusion and the other is osmosis. All occurs from the synovial fluid and the subchondral bone. Mechanical loading also plays a key role in delivering nutrients, as compression and decompression help fluid exchange within the cartilage tissue. The physiological loading of the cartilage, where the controlled movement and weight bearing takes place, improves joint health by stimulating collagen synthesis and promoting cartilage stiffness. However, Excessive or non-physiological loading leads to cartilage breakdown, increasing pro-inflammatory markers like interleukin and TNF-alpha, which accelerates degeneration. Cartilage lesions can be classified into two main types as degenerative lesions, which are seen in osteoarthritis and involve irregular edges and widespread damage. Focal lesions, which are localized and often found in young athletes, and if untreated, to those focal lesions that can also progress into more widespread degeneration. Cartilage injuries significantly impact joint function. Patients experience severe pain, swelling, stiffness, and also in very severe cases, mechanical dysfunction like catching or locking. Studies show that patients with cartilage defects often have worse knee function than those with ACL injury, highlighting the importance of proper diagnosis and management. Cartilage defects can arise from acute trauma, repetitive microtrauma, ligamentous instability, malalignment, or meniscal insufficiency. High impact sports, contact injuries, or even chronic overuse can lead to progressive cartilage damage, increasing the risk of osteoarthritis over time. Cartilage injuries can be managed through both a non-surgical and surgical approaches. Non-surgical treatments include physiotherapy, pharmaceutical, weight reduction, and activity modification. While surgical options include microfracturing, osteochondral transplantation, and autologous chondrocyte implantation. Post-surgical healing occurs in many phases. Initially, a fibrin clot forms, followed by gradual tissue remodeling and integration of new cartilage. However, cartilage repair tissue often lacks the biomechanical properties of the the initial cartilage, that's why I'm saying the requirement of a well-structured rehabilitation program following those cartilage injuries. So, let's move on to the rehabilitation, which is the most important phase after the operation, after the post-operation following a cartilage lesion. Rehabilitation is divided into three main phases: the protection and activation phases that occurs from 0 to 8 weeks, where the joint stability is prioritized; the loading and functional restoration phase from 7 to 12 weeks, which focuses on controlled strengthening; and the activity restoration phase, which is running from 11 to 52 weeks, where we gradually return to high impact movement. Return to sports should not be time-based, but criteria-based. The athlete must have no pain or swelling. Also, he should present it with good MRI findings and should pass functional tests like the HOPE test, strength symmetry assessment. Rushing RTS or the return to sport can increase the re-injury risk. So, it's crucial to ensure full recovery. So, to summarize, the cartilage lesions have poor natural healing potential, and early diagnosis is essential to prevent osteoarthritis, which is the most severe degenerative lesion that occurs in knees, in the cartilage. Rehabilitation should be structured and progressive, with return to sport guided by functional assessments rather than a fixed timeline. So that concludes our session on cartilage injuries. The key to successful management is understanding cartilage biomechanics, optimizing rehabilitation, and ensuring safe return to activity. Also, I have put some MCQ and SEQ questions like in my previous lecture. So we will quickly discuss the MCQ questions. First question: what makes cartilage injuries challenging to heal? if you can remember, if you actually listen to my presentation from beginning to the end, you must have heard that I was repeatedly telling you that cartilage tissue is very challenging to heal because it's avascular, aneural, and alymphatic nature. So the answer is obvious, it's C. Coming to the second question, which zone of articular cartilage provides wear resistance? Obviously, I mentioned that also in my presentation. That is the very superficial zone. Third one, what is the primary function of the proteoglycan? So I told you both proteoglycans and glycosaminoglycans, they're having a higher attraction or higher affinity to water. So its main function is to bind with water to resist high compressive force. Fourth one, which of the following is not a characteristic of our osteoarthritis related cartilage lesion? Normally, OA characteristics with very initial stages can occur in young athletes too, but not the severe form characteristics of osteoarthritis. So we can't expect the osteoarthritis related cartilage lesion primarily in young population of athletes. Fifth one, which treatment method involves controlled perforation of the subchondral bone to stimulate repair? It is microfracture. You can read around. I will add some reading materials as well. What is the primary role of controlled joint loading in cartilage rehabilitation? It is to stimulate nutrient diffusion and extracellular matrix reduction. Finally, what's the best imaging modality to assess the cartilage repair outcomes? It is the MOCART case that we derive from MRI imaging. So, as usual, I have put some SEQ questions also, to which I have put the answers in my description box for your reference. So, hope you enjoyed today's session on the treatment of cartilage injuries. If you have any questions or any queries, also any suggestions, please drop them in the comment section. So I will come up with the third lecture, that is about the treatment of bone injuries, in the next session. So until that, bye. See you.